We will start the meeting then.
Yes, sir.
Can
I
you
give you
please
count.
start the countdown?
Yes, sir. So we are
Yeah.
starting in 3, 2, 1. Please start, sir. We are live.
Okay.
Okay, I
So,
hope I am audible. I'll start the video also.
yeah.
Okay, I'll share screen and then we'll start on the topic. Okay.
Okay. Okay. So we are having Dr. Mahashri Mitro from Kolkata, Silverline Eye Hospital. And sir, the first topic is by sir, translating research into practice, real world application of DME management study. Sir, you can start.
Okay, thank you. I hope my screen is both visible and I am also audible. So we will start with this.
Yes, sir. Audible.
Okay.
Yeah.
So the topic for discussion today is translating research into practice, real world applications of diabetic macular edema management strategies. As you all know, there are lots of RCTs that have taken place regarding the proper management strategies, the different drugs, different outcomes. So it has evaluated a lot of things, but all of them has been in the clinical trial design and settings, which is a very strict criteria which are followed for inclusion of patients, and that limits the generalizability of the results to the broader patient population. See, and the thing is, it's very difficult to use that knowledge exactly and use it in very similarly or exactly the same way in the real world patients. And a lot of these approaches have been tried, like Tritanexin, Clorenata, monthly injections. But again, in real world scenarios, always it is not exactly possible that way. The clinical trial results may not fully reflect the real world complexities of the disease and more so its management. So there are quite a few things we would like to talk about here. This is the current landscape of anti-VEGF injections that is there. So the rise and ride. In this, we have seen how ranibizumab works against sham, and it is proven quite time and again that it is a fantastic drug. But what about the other ones? For example, eosamide, it was another trial where faricimab, different dosages, and Eylea were compared. And it was found that Eylea was faricimab was found to be non-inferior. So they were comparing it to Eylea, as because Eylea had been in use before. So again, it's a very good study there. Other studies like where brolucizumab and aflibercept have been compared head-on is one more studies like the Kite and Kestrel. Again, this shows that the brolucizumab is again non-inferior to aflibercept. Now, these are the different scenarios we will be talking about. The Vivid and Vista. Here, aflibercept different drug regimens have been tried, and all of them have been found to be quite effective, but we have chosen the ones which we really need. In the DRCR Net 2 also, there were protocol T especially, has a lot of injections that is being used. One very important point here is that aflibercept clearly we will discuss this a little further later, that aflibercept was a clear winner the first year. Results or the markedly better results from aflibercept did not maintain throughout the year 2 when compared to ranibizumab, but it did maintain higher vision, higher quality, higher efficacy when compared to bevacizumab. Now, so what world model? Why do we need real world studies? We need real world studies because a lot of patients that come to our clinic, not all of them are in the ideal scenario in which they should come. In clinical trials, we do not include a lot of patients who have a lot of comorbidities and all, for example. So here what we do is, this measures the real world effectiveness of the drug in the clinic. The patient population is not selected at all. It is not pre-screened. It is mostly patients who are just comes to your OPD, complaining of the visual symptoms, and we treat them on the basis of the findings that we find at that situation. Typically includes very diverse outcomes. So what it does, it provides information on patient impact. It provides information on worldwide differences, and it provides information about value of treatment also. Now, this endurance study is one particular, which actually this was the extension of the study from 3 years of the VISTA study, because VISTA was done for 3 years. It was a 3 years follow-up. It was published as VISTA and VIVID. So the VISTA particular part was extended by up to 2 years. And so what did that show? Patients were observed with aflibercept, definitely. It was patients were observed at 4 weeks, 8 weeks, or 12 weekly intervals, depending on the disease stability. There was a substantial reduction in the treatment burden through years 2 of patients, because around 25% of patients required, and 48% of patients received less than 5 injections in the next few years. Now, this is another study called DRACO. These are all real world studies. These are not the ones which are following the strict criteria. And so this is what we can use it in our clinic much more than the information we gather from the clinical trials, the RCTs, or the randomized controlled trials. And here what they have done is they have compared the different BCVA, they have categorized into different, I'm sorry. Yes. Here, the patients have been categorized into different vision categories. Excuse me, I'm having some problem with this. Yes. So there, the vision with the people with baseline, I'm so sorry. It's acting up. It's going to the last slide repeatedly. Okay, so let's keep it like this. I will keep it like this. I hope it's still visible. Yeah, here different visual acuity groups were considered, where the number of letters which could be read at baseline, patient was divided into those different things. So patients who had the lowest vision is very natural, for that is true for any and every anti-VEGF for that matter. The mean baseline visual acuity here was 71.4 liters. The mean change at month 12 in treatment naive patients was only 2.5, it was plus 2.5 liters. For those with baseline visual acuity below less than 70 liters, the improvement was much more. And for more than 75% of patients, the rear severity level, which is also a very important parameter here, remains stable from baseline till month 12. So there was at least no worsening of the disease for more than 75% of the patients who have been receiving the injections. But it is also to be noted here that the people who had the maximum amount of the most visual loss needed the most injections also. Now, this is one more study. This was done by Debdulal sir et al. And this study compared aflibercept. This study talks about the effectiveness of aflibercept in recalcitrant cases. So what do we use in recalcitrant cases? How do we go about using anti-VEGF? See, initially we start after we have, now we know that after all the studies of after our own experiences, that anti-VEGFs are the gold standard for all diabetic macular edema. So we start treatment with anti-VEGF agents. Sometimes, depending on the stages of the disease, we start with different anti-VEGF agents, but usually we end up starting with bevacizumab, which is quite not very easily available nowadays, or ranibizumab. So next one, what we do, if it works fine, it works fine, great. If it does not work, we plan to switch. So if we are using a bevacizumab, we may think of switching to a ranibizumab. And in case we have been using ranibizumab, we think of shifting to aflibercept. And there may be usage of some the newer drugs also, like brolucizumab, but that is not the topic for discussion right now. So one more thing which we use in recalcitrant cases is dexamethasone implant, where we change the drug category altogether. So this was a particular study. This was a study where aflibercept and dexamethasone implant for recalcitrant diabetic macular edema in pseudophakic eyes were compared. So this pseudophakic eyes only pseudophakic eyes were included in this patient. in the study, sorry. And the outcomes included vision improvement, CMT reduction, injection frequency, and the parameter of IOP change also. So there were 84 eyes which were grouped at different groups. And both of them, after receiving aflibercept group and the dexamethasone group, had almost similar improvement. But the intravitreal aflibercept had a 6.5 times higher likelihood of 3-line improvement. More injections, it is true that more injections were needed in the aflibercept group, but at least that group did not develop high IOP. Higher IOP was found in the DEX group at around 6 to 9 months period, with 13% needing IOP lowering medications. Not all needed IOP lowering medications. Now, this was actually the All India Ophthalmological AIOS Diabetic Retinopathy Task Force. This is the published diabetic macular edema treatment guidelines. Sorry, the intravitreal injections of anti-VEGF agents, like it has been said, for the treatment naive center involving diabetic macular edema, that anti-VEGF therapy is the most helpful. The most common reasons for non-response to anti-VEGF therapy is due to inadequate treatment as per the protocols that should be used. And aflibercept was found to be, like I was saying before, that a patient has been started on bevacizumab, a switch to ranibizumab or aflibercept is accepted. But if the patient was on ranibizumab, a switch to aflibercept per se is advised. Now, we will go into a few more studies. Before we go into a few more studies, we will just discuss the hierarchy of evidence-based medicine pyramid once. So what is the highest level of evidence that we all know of? We are trusting in RCTs here. Now, RCT is also a level 1 in evidence, but even higher evidence or even higher level of evidence is a meta-analysis or a systemic review. So the lowest ones are at the level 5 is the editorials, the expert opinion. Case number 4 is the case series. Level 4 is the case series or the case reports. There is systemic reviews of case control studies, that is level 3 evidence. Individual case control studies that also belong to the level 3. Systemic or reviews of cohort studies belong to level 2, and individual cohort studies and low quality RCTs, which are not conforming to the stricted standards, are also belonging to level 2. So here we will be discussing about a highest level of evidence. That is a systemic review or a Cochrane meta-analysis we will be discussing about. The Cochrane meta-analysis reviewed evidence from major studies. So how many patients? This included 24 studies and 6,007 patients were considered. And with DME and visual acuity, generally of these patients were between 20 by 200 to 20 by 40 at baseline. So what were the outcomes that were found from this? All efficacy outcomes significantly favored aflibercept at year 1. See, at year 1, we have seen other studies also. So at year 1, we would like to say, put it like this, that all anti-VEGFs in good vision or work quite well. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept than ranibizumab bevacizumab at year 1. And for every 1,000 people treated with aflibercept, that means yeah, so 92 patients would gain, means suppose 1,000 people were treated with aflibercept and 1,000 people were treated with ranibizumab. So 92 people more in the aflibercept group would gain at the end of 1 year, would have gained more than 3 lines, more than that in case of ranibizumab. So that also favors the use of aflibercept in such cases. Other meta-analysis, there are different meta-analyses which have been compared. Aflibercept 2 milligrams Q8, that is in 8 weeks, that is 2 monthly, consistently showed evidence of superiority compared with ranibizumab 0.5 mg, but at that is, oh my god, Hey, can somebody from the tech team, could you please share the slides from your end if you could? Because this is becoming very difficult here.
Please share your slide, sir. Stop sharing and share again, sir. It will.
Okay.
Yeah.
Okay, I hope I'm visible again.
Yes, sir.
So aflibercept 2 mg at 8-weekly interval showed superiority over ranibizumab on PRN regimen. So there is nothing surprising in that. And aflibercept was again found to be the most favorable treatment in terms of BCVA improvement and CMT reduction when compared to other therapies in the management of DME within the first 12 months. So there are other few guidelines which we would like to talk about. The EURETINA guidelines published in 2017 also take aflibercept as a drug of choice in DMEIs with baseline visual acuity, which is poor, that is 20/40 or worse, as it shows superiority over bevacizumab over 2 years and ranibizumab in the specifically the first year of injections. The Asian recommendations in patients with worse visual acuity, aflibercept may result in a more rapid visual improvement than ranibizumab. And in Diabetes Canada guidelines also talk about the superiority of aflibercept was noted in the group of participants with worse baseline. So what from the different guidelines, what we come to understand is that there are quite a few, though there are quite a few anti-VEGFs available, aflibercept was the drug of choice in most of the poorly controlled, or maybe the poorly controlled ones, or the ones with poor vision, where there was a lot of improvement at the end of the treatment period. Now, aflibercept is already recognized as one of the standard of care in DME and is quite it's widely being used in quite a few other DRCR network trials also. We all know about the protocol T, protocol V, but protocol T and protocol V have been there for quite some time. But recently, there has been the newer ones, that is the protocol W. We'll just mention what it is. An intravitreous anti-VEGF agent injection for the treatment of prevention of vision-threatening deer in eyes at high risk. That means this is not only about diabetic macular edema. This is about preventing DR, preventing PDR, preventing escalation of the disease to high risk. So this is trying to stop disease progression. This is one. And protocol A, we have learned much long before, but again, now it's protocol AB, that is intravitreous aflibercept was also considered here versus prompt vitrectomy for vitreous hemorrhage from PDR. Again, this showed similar results in the initial follow-up period. So that means that if at sometimes it's quite possible that by the use of aflibercept, we can delay surgery also. Protocol AC, the randomized trial of intravitreous aflibercept and bevacizumab versus, this is like, it's in the comparison between intravitreous aflibercept directly, or it's versus initial bevacizumab and then switch to aflibercept. So there are quite a few protocols that are being evaluated now. This is the another FRB, or the registry for this FRB registry. Actually, it's an European thing. What happens is there is a lot of things which happen all over the world. They take care of these things. They take note of all the different studies that are going on, and they accumulate the data at one place, so we can have meaningful information out of it. So this is different studies. And so what is the FRB registry saying? That patients with baseline visual acuity less than 68 letters achieve significantly. So basically, different studies. Again, it says the same thing, that people with worse vision are gaining the most with aflibercept injections. And this is the study where it has been compared with ranibizumab has been compared with aflibercept. So differences between aflibercept and ranibizumab persisted throughout year 1. Again, we have talked about this also previously. There was a study conducted by Moorfields. Here again, like I had talked in one of the previous studies, the people have the participants have been divided into different visual acuity groups. And again, it is seen that people throughout this, and the best thing here was the baseline vision improved. Actually, the improvement of the baseline vision was taken care by, looked after from year 1 to year 2 to year 3. Maximum number of injections were needed in the first year. Around 3 injections were, that is approximately 7 injections. At year 2, approximately 3 injections were needed. And in the year 3, a mean of only 2.5 injections were needed. So what does this again show? People with worse visual acuity have a lot of number of visual ETDRS letter gain. That is, the visual improvement is much more. In the first year, the improvement is seen to be of approximately 17 letters. In the second year, though that much of improvement is not there, but an 11-letter improvement is sustained, which is gained in the year 2, is also sustained in year 3. Now, people with much better visual acuity, we obviously do not see that there is a lot of difference, not a lot of gain in letters. But again, it is shown that the the injections try to help in restoring or staying with the same level of vision for the longer period of time. Now, eyes with baseline visual acuity of less than 69 letters achieved a mean visual acuity gain of more than 8.5 ETDRS letters by year 5. 32% of the people gained more than 10 letters from baseline to year 5. And 19% gained more than 15 letters from baseline, which is quite a lot of visual improvement. But one more point to be noted here is that around 20 injections were needed from baseline till year 5. But overall, like to counter that point, overall, nearly 10% of eyes required only 5 monthly injections in the very beginning, and no further injections were injected at all during the course of the rest of the 5 years. So that is also a very good thing, but I'm sure that it is possible only in a few cases. One more study we'll be talking about here, and we will end with that. Apollon is a French study. It's a real world evidence. It was a multi-center prospective observational study of 168 treatment naive or previously treated patients with DME. Here, actually, we cannot compare between 2 different trials, or because the settings are different, the criteria are different. But here, for a brief idea, it has been tried that in the RCT in the VIVID showed an improvement of 9.4 letters and an average injections of 14. And Apollon in the real world showed that with lesser injections, still quite a lot of vision could be improved, around 6.5 letters. 52% of treatment naive patients received early intensive therapy with 5 monthly doses. So here, what is important is, like we mentioned earlier, that initial intensive therapy is very, very important. So if the initial therapy has been intensive, I think the improvement of the vision, and the reduction in CMT, all of these can be sustained much more than dispersed use of injections. So 61.1% of treatment naive patients achieved driving vision. That is very good. That is more than 70 letters by the end of 2 years follow-up period. So again, outcomes achieved in treatment naive patients, a real world setting, were quite similar to those that were reported in the randomized controlled trials. Thank you. So basically, to say is what do I have to summarize basically is that aflibercept is a very good drug of choice. I know that we do not use it all the time as a first line of treatment, but it has been shown that it works quite well in as first line also, and in quite a few recalcitrant cases also, and it is also comparable to dexamethasone without the complications of higher IOP. So, and even in the real world scenarios, the comparable results to RCTs can be achieved with aflibercept. Thank you.
Thank you, sir. Thank you, sir, for the insightful presentation. So now, my colleague Rishikesh is there. Kindly check Rishikesh whether Kekerai sir has joined or not. Meanwhile, we are open for the discussion. If there is any question, you can ask from our speaker.
Good evening, Mohit. So unfortunately, we're not able to reach Dr. K.K. Roy. He had a flight to take actually for his family reasons to emergency. So I think we can go with the audience for the query. After that, the meanwhile, I'll try to reach again. If no, then
Please try to reach him and let us know what is happening.
yes, sir, yes.
Yeah, just now I have a talk with Dr. KK Rai sir. We have to wait for another 5-6 minutes. He is joining. Hello, Rishikesh.
Yeah, yes.
Yeah, yes. Rishikesh, can you please connect to Dr. KK Roy, sir? He told me that he will join within
Yeah,
6
I
to
have
7
already
minutes.
had word with the Dr. KK Roy.
Hmm.
So he's like saying he is just landed.
Hmm.
So within a couple of minutes he's joining. Right? So
Okay. So I would like to request our tech team to please bother with us, and thank you for the all the audience to bothering. We will our speaker will join shortly. Rishikesh. Uh,
Hello. Yes.
yes. Can you please check with Dr. KK Roy sir to join?
Just
Yes,
couple
yes.
of minutes back, I just called Dr. KK Roy sir. Sir has told me he's joining, but not not yet getting him in the meeting. I don't know what is the reason.
KK Roy sir has joined. Yes, his video is visible. Sir, good evening. We are waiting for you only. You are muted. Yeah. Please unmute, sir.
Now I am mute, right?
Yes. Right.
I am audible.
Yeah,
Yeah.
you're audible, sir.
Thank you. Sorry, I did make a huge inconvenience for you people.
We can
So
understand.
now
We can understand the
we
situations
can
and-
we can start the presentation, right?
Yeah, absolutely, sir.
I share my screen. Now my slide is visual, right?
Yeah, it's visible.
Yes, sir. Your slides are visible. Please continue.
Okay. So next 5 minutes, now start. So good evening, everyone. So we're going to discuss about visual outcome in DME, assessing the efficacy of aflibercept injection in 16 weeks. So next, right now, diabetes burden in the world is huge, and it's going to be continue to rise in the next 30-50 years. And if we talk about India and East Asia, this rise is much more compared to developed country. In Southeast Asia, the rise is never to 74%. Among these, rise in India especially is very high. Now, the proportion of patients of the diabetes that have site-threatening diabetopathy expected to increase along with this diabetes, rising diabetes population. So, it's a leading cause of vision loss among the working age group. In 2020, it is estimated that 28 million people had diabetes throughout the world. Now, vision loss is the among all the complications in diabetes. Vision loss is the most severe complications in among all the complications. So, if one study shows that in working age group, 50% patient they lose their vision, whereas 21% have cardiac problem, and only 9% have foot and leg related problem. So it's a causing disability to the level that patient working capacity decrease. So it's a burden causing their day-to-day income. So it's a more feared complications among the patients with diabetes. Now we have effective treatment opportunity which we normally get after giving the injection. And for us, to the patient, one line improvement or two line improvement, but the meaning of one line improvement to the patient is different. If patient again one line improvement, he can read a newspaper or drive at night. If a patient gain two line improvement, that means the patient have a near vision task like cooking, using tools, or work performance is much better. If a patient gain three line improvement, that may improve the perception of color. So maintaining more than 20/40 vision may help the patient getting the driving license, reduce the medical illness compared to patient less than 70/80. So our motto of diabetic patient or diabetic macular edema patient treating, keeping their vision outcome more than 20/40 or 26/12. Now, the efficacy of aflibercept, we all know it's worked in diabetic macular edema. And all the long-term study, Vivid and Vista for 3 years, DIAS and .NET, Protocol T, they all tell us it is for long-term, the efficacy of aflibercept is much more compared to others. Indian study also, they show us for long time, for 5 years, it have their effect. And if we saw about international recommendation guideline among the first line use of diabetic macular edema, aflibercept came in a patient where patient initial visual acuity less than 6/12 or less than 6/20. In this group of patients, aflibercept is the first choice internationally and based on Protocol T trial. So this is the same things happening in European guidelines. Multiple study also give us this kind of report. Now, aflibercept is recognized as standard care in DME being used in DRCR network protocol evaluating anti-VEGF DME. So, aflibercept retina network shows us that in Protocol T, it is not only effective, but also if a patient initial visual acuity is less than 6/12 or 6 by less than 20/40, it works better than compared to other agent. Now, Violet study is another long-term effect of aflibercept study where we long-term see the benefit of aflibercept in DME patient in different region, early intensive therapy in 1 year, patient in AQUA study. So, in this study, we randomize the patient in 1:1. First term, we have to give the 8 weeks interval fixed treatment for 2 years. And second term, we go for treat and extend. And third term, we go for PRN. So, in these things, we saw that ultimately, after 3 years, the aflibercept works for this patient. So, in the study, page maintenance long term is there. In baby study also, we can see that for long term, this aflibercept works. This is another study trial. They advise treat and extend therapy with aflibercept present in DME for over 2 years. And in aflibercept, mostly patient maintaining 4 weekly for 5 months, followed by treat and extend is there, and 2 years we normally follow. And in this study, majority of the patient achieved 16-week treatment interval for individualized treat and extend regimen with aflibercept initiated year 1. Here it is another arm where evaluate a protective treat and extend regimen aflibercept for patient with DME. Normally, we endpoint is 52 weeks, where it is shown that aflibercept treat and extend initiated 5 monthly loading dose provided significant visual improvement in patient with DME. In prospective clinical study, majority of the patients with DME achieve more than 12 weeks treatment interval after 2 years of protected treatment trial in aflibercept. In summary, aflibercept can achieve clinically meaningful vision gain or maintaining vision regardless of baseline vision, and is the treatment of choice, especially if a baseline vision is less than 20/40 or 6/12. Early intensive therapy followed by treat and extend regimen in DME can also maintain vision and reduce burden to patient and clinic. Patient factor beyond baseline vision such as duration and control of diabetes can also be important risk factor for vision loss in patients with DME. Overall, early treatment for DME with good systemic control and regular follow-up, patient can maintain vision for a long-term period of time. Aflibercept is only bispecific anti-VEGF fusion protein that designed to trap VEGF and PIGF. That all did you know. Early intensive therapy with DME may maximize the vision gain for the first year, and this can be maintained in long term with reduced treatment burden. With protective individual dosing, patient can maintain visual gain with reduced treatment burden after 1 year with aflibercept. Emerging real-world study also show that aflibercept leads to good visual and anatomy outcome in clinical practice that are consistent with those reported in clinical trials. Thank you.
Thank you so much, sir, for making it like the situations we can understand. So this we can open the forum to audience for query or maybe any further clarifications on the presentations. We can take a couple of questions if so. So otherwise, we can close the call, I think, if there is no query. And once again, thank you so much. Thank you, KK Roy, sir. Thank you so much.
Thank you.
Morsi, sir.
Thank you all of you for waiting for me and giving this opportunity in this hard situation.
Yes, sir. Sometimes it's happened.
Thank you, sir.
Out
Thank
of
you.
our.
Yeah, thank you.
Krishnakanta
Good night.
sir.
eh?
Good night, sir.
Good night. Good night.
And
Okay,
Moashi sir
okay.
also, good night, sir. Good night.
Eh.
And all the audiences, thank you so much. Good night. So now we are good to close testing. Kindly close the meeting.
Yes, sir. Thank you.